you, sir. So thank you so much, Manish. Hope you heard what I said in the first line, that I was overjoyed when you asked me to speak about burns than other physical trauma. Because in the last 30 years, I found this is much more challenging to get equally good outcomes in burns. And I thought I should just short 15 minutes talk as to what I should speak. Because burns can come in as a very small burn, or it could become as a disastrously big burn, and each of it has its own issues, but all of them causes a tremendous amount of anxiety in the patients and their families. So if you take the basic principles, I'm only going to talk with this, finish with this slide, and I'm going to tell about what I felt as important in this last few couple of years. So all of us know that burns, major burns, or to 20, 15, 20%, all of them require admission, and most of them after that they require resuscitation, and circumferential burns require a hysterectomy. And in case now, in case of electrical burns, they also require fasciotomy. I think these fundamentals all of us know. And burns is like any other trauma. We also know whenever it comes, you also have to go through ATLS protocol. I think that's given. So having said that, we understood this. I think where are the things? How is this burns differ from other forms of trauma, which we are really fighting hard to understand? The thermal trauma is more challenging than other trauma, physical trauma, because the magnitude of the systemic response is always higher. Now you find the fellow comes in 4 pieces, he's got a multiple polytrauma, and then we resuscitate them. We find we can take them up for next stage of surgery. We can take them for major surgeries, and they can become all right in about a couple of weeks. Well, it's not so in burns. The magnitude of systemic response the body puts up is much higher, and it lasts longer for longer time. The second thing is resuscitation endpoints are reached much earlier in other forms of trauma. Even hypovolemic shock, if you are able to control the place of bleeding and all that, so you could reach the resuscitation endpoints, you can reach faster. But whereas in burns, we are not able to reach that. That is one. The next is the cost of care is always higher. And if a complication should happen, it becomes astronomically higher. So it's a very resource intensive, skill intensive, I think labor intensive, and time intensive specialty. So the stress response in burns, as I said, now how is it different? See, long back now, when we were in physiology, we read this. That is, whenever there is a major injury, I think body responds by this way. That's Cuthbertson's ebb and flow hypothesis. So there is an injury, and then what happens is you have ebb phase that lasts for about 12 to 14 hours. There's a decreased cardiac output, decreased tissue perfusion, reduced oxygen consumption, the metabolic rate is low. So that's what happens. But then you get onto a flow phase where there's increase in metabolism, body temperature, everything increases. And when this it reaches normal in course of time, when you do the surgery and then make it all right. Whereas there's a normal phase that go. But whereas if you compare this normal in the case of burns, what happens is that it doesn't reach normal at all. I think it keeps on going. And if it tries to get to normal and then you get a hit infection, episode of infection, then again it goes up. And then you get some raw areas, you get another surgery, then again goes up. That means it keeps on going for longer and longer. And this hypermetabolism, I think it lasts for a long time. I think it shoots up and lasts longer. So it means these are all starvation and all. I think if you have severe sepsis, it goes there. And this that other polytrauma that we had, the skeletal trauma that we get here, but then the major burns it get here. So that's one different challenge that we have. And it is shown by the amount of epinephrine levels and cortisol levels. You'll find if that is the normal level, you will find norepinephrine levels both in the blood and the urine they stay longer. Cortisol levels are longer. So this part of it now we need to remember so that now we can. So how do we treat this metabolism problem is you need to increase the anabolism. That is, you need to exercise, you need to do the surgery faster. And the nutrition is a very, very appropriate thing in physical therapy. I'll come along them in the talk. And we need to reduce the catabolism. That's you prevent it by infection, you prevent hypothermia, you prevent hyperperfusion by resuscitating them well, and you prevent acidosis. The next problem we found that is unlike other forms of trauma, I think all trauma science need to know, is about the nutrition in burns. So you all of us know that if you have underfeeding, if you have underfeeding, you get muscles get wasted. There's a poor wound healing and all that. I think all of us know this. Overfeeding causes these problems. But then in burns, there's a tremendous amount of underfeeding. And all of us know what lean body mass means. I think the body or the mass of the body that's not fat. 10% of reduction of lean body mass lead to impaired immunity, and 20% of loss of this impaired wound healing with us with 30% mortality. In 30% loss goes to 50% mortality, and 40% when it goes, all of them die. I think that this is a very important fact. I think in burns, you reach this state very fast. I think unless you take care of this, I think that's one of the causes of death. And protein metabolism again in burns, you find the muscles only break down the muscle proteins to produce more glucose. That again happens. And as much of more loss of muscles that you have, that means we will not be able to use the glucose. As much of 150 grams of skeletal muscle is lost per day in the absence of adequate nutritional support. I think that's the biggest problem. And in the burns unit, we find that one of the other things we have to take as a trauma care is that you need to take care of the nutrition. And timing of feeding is that you need to do it as early as possible and as continuous as possible. And full feeds can be started as soon as the surgery is over. And even when there is a hemodynamic instability, I think you need to really give rise to the feeding part of it has to be continued. And when the hemodynamic instability comes in, you put a high dose of vasopressors, it gives mesenteric ischemia, and then going to problem. So that's the reason why we need to really resuscitate them well. The third point where I found difference in burns is with other trauma is infection. In skeletal trauma or where this extremely soft tissue loss, we always found it easy to control infection, whereas it's found to be very difficult with burns. Why is infection important? Because once the patient survives hypothalamic phase, the infection and hypermetabolism are the two main reasons for morbidity and mortality. And burn patients are all of them are immunocompromised, and hence all efforts should be made to decrease the infection. And the onset of infection retards healing, and graft take is poor, and it converts the partial thickness burns into a full thickness burn. It's so surprising because it's so challenging because initially when the burns come, I think it's due to heat, all of them are sterile. That means there are no infection, but all infections that happen to burns patients are happening in the hospital. I think that's the reason why we need to be very careful. And you find if there is a skin loss or in a necrotic tissue there in the shirt, the bacteria double 2 to 3 times per hour and become 10 million in one day. I think that again is a very important point. But all of us as trauma surgeons know about the definition of colonization infection. But then what is really required or what really matters in burns is it's not a question of colonization. It's the issue, the amount of infection that happens in the tissue. I think that's what is very unfair. And most of the times when you get the invasive wound infections, I think when it gets into the tissues, I think it becomes a surgical emergency. And then we need to debride it. I think we need to really debride it. We have to resuscitate the patient and put them on to appropriate antibiotic. Now, what has made the difference in burns is, I would say, for the trauma stage, just like you debride a wound normally, I think if you have a physical form of trauma, you debride and cover them early. I think the same thing has happened in burns is that you also excise the burn early and you promptly autograft. If you're not enough of skin to autograft, I think we need to get it from the skin bank so that you do. And these are the things which you made it. But then the top in the list is early wound excision is the most important thing. Why surgery is because that has become the standard of care in most of these major burn centers. And I found that if you do early surgery, it reduces the release of inflammatory mediators early. And the chances of for them going into multiple organ failure is much lesser. And multiple random control trials comparing early excision and traditional methods of treatment, they always have favored early surgery. If you're going for a conventional treatment, I think particularly for major burns, I think minor burn doesn't really matter, we found it. But a major burns, the consequence is very much because they always are going for infection, granulation in tissue, and then once the infection sets in, it always goes into a very bad negative cycle. We find that the burn wound is the source of all evil. So what I would say is that I think we need to change paradigm shift. We have to take place. And as we do all the major trauma that we take, I think we should also do the same way. I think the burn wound, I think, needs to be excised. The necrotic cells, the denatured platelet have to go. Once they go, the inflammatory mediators are becoming lesser, and the local and the systemic inflammatory response becomes less, and the patient, goes on to a path of good recovery. And you have got a number of articles that come up to say that is the better way of doing it. And a few points now, what we have to, as Thomas is we need to understand. Once there's a major burn, they got a high risk of hypothermia. I think that again we need to take care. And if you have a hypothermia, these are the problems that happen: arrhythmias, coagulopathy. I think when the body temperature goes down, the chance of infection is also it becomes much higher. And one special problem that we have is inhalation injury of burns. I'm sure it will be covered up in other places now, so I'm not really getting onto that. This really now makes up the mortality higher. The burns can occur with other injuries. I think a series of cases that we had, particularly during the monsoon times, the electric men, they get injured. They fall off, they're shot away by electric shock. Not only they get a burn, but they also have spinal fractures or long bone fractures. So all of us need to really take care about that. You need to go through the ATLS protocol when you see any major burns. So finally, where are we now? I think the burn problem is very high. I think all of us know more than 1 million burns happen every year in India, and most of them are preventable. I think there's a very good article which has happened. I think both Manish Sheil and us may have been co-authors of article which has been done by plastic science from Michigan. It's a nice article which says about the real status of what is the status of burn care in India, as the geospatial mapping is a guide for resource allocation. In that article, they have found about 67 major centers, and the number of beds is hopefully short. But the one thing that is surprising is that, and you will find that any place in the country is only 3 hours away from a major burn center. I think it's possible to, by in 3 to 4 hours, you should be able to reach some burn center or some specialist center you are able to reach. That's good. And the emergency progress available within 1 or 2 hours. If it's gave, that means you get a very good repair. And this is what I said in this article we found. I was also very surprised with the findings. Within 2 hours, you should be able to go. And 15% of the people, they have an access to ICU care. And if you see the world, what has really happened, the 50% survival rate has increased from 35% to 80% of burn surface area in the past 20 years. I think from the antibiotics, this is the scale, I think how we reach. From 50% survival, 55 to 80% it has reached. And the LA50, there's also really has come down. But then we have a long way to go. I think this is an article which has come up from North India. You'll find the number of deaths, number of cases, the number of deaths, almost 100%. And a publication also came from South India. I think almost the same. I think nobody over a period of 60% consistently survives. I think that has been both in North India and South India has been there. Why is the mortality high? I think there may be many reasons for that. But then there is always the silver lining. I think if we shouldn't have been taking every step that has been taken by all of us. I think we need to take to the state. I think what has been proven as the best of care in other centers, I think we need to take. And for that, one of the things is that early referral to a burn center is very important. And people say that people have been assessing, we have been assessing death, standard of care by the death rates. But most important is that the quality of life is their point of how the people have started assessing the burn care. So skin banks are also very needed badly. I think once the skin banks come up, I'm sure our results also will increase a lot. So the way to go, I think, is that if you have a major burn, I think the burn people have got a higher chances of living if they are referred to a major burn center. I think every burn, more than 20%, if it gets to a specialist center, I think there is a trauma surgeon we need to recognize. And as a trauma surgeon, before referral, you need to recognize whether there is a need for emergency surgery in the form of splinting of fractures or other things like other associated injuries, or whether the circulation is impeded to any other part. I think barring these two conditions, I think if they are able to send to a different burn center, I think our results also could improve so much. So thank you so much, Dr. Manish Singhal, for this opportunity.
Thank you, sir. Thank you, sir. Narendra, do we have any questions from the audience or anything, or because sir has to leave for another meeting, so, or I will ask sir. So can I ask a question, sir?
Yeah, sure, Manish.
Sir, I have seen most of the setups, even the general surgery people also manage burns, and they are also having a nice burn center. And I feel the plastic surgery community is little small to manage burns.
Yes.
So, what additional skills a general surgeon or a trauma surgeon should have if he doesn't have a option to refer to a burn center, so that he can at least manage for maybe initial week or something the acute burns? What additional skill they should learn and from where?
No, if I also used to think about this, Manish. You find in the first week of resuscitation, I think that doesn't require any additional skills. I think it requires one good intensive care and somebody who to recognize whether there's an inhalational injury and then ventilate. I think that's the one which is I'm sure now which will be available in most places. And I think we can go by step. If you find, if you think there are a large area of a full thickness burn, I think early referral, I think that's what is the one, that's the only thing which can really make it as early referral to a burn center is the only thing. So there's a question of scoop and run or stay and play. So you find that if they recognize that the considerable part of the burn is a superficial burn, that means they could manage with it in the same center. And if they could prevent infection, I think they all will survive. But then if you think that is a larger burn, which has got a predominant area of full thickness burn, that means that recognition and referral to a bigger center should be fine. Otherwise, it becomes a very big, difficult process to manage.
Okay, sir. Thank you, sir. Thank you. Thank you very much, sir.
Thanks so much.
I think Narendra
Nice of
sir.
you.
Thank you, sir. Narendra sir has to leave immediately because he has another talk, international talk. So if you permit, he can leave the session in between.
Right, sir. We have a lot of, but we can address the sir on the mail, and we will get mail to the sir for the queries. And citing the time limitations, I think we can permit sir to leave the meeting.
So thank you so much. Namaskar.
Thank you, sir. Thank you very much.
Bye-bye.
Over to Professor Vivek, sir.
Okay, so good evening, everybody, and let me thank the organizers for inviting me as a chairperson out here. I would like to introduce my good friend and colleague for the last 25 years, Professor Vijay Sharma, who is an expert in trauma surgery in orthopedics, especially in pelviacetabular surgery. He does all these complex surgeries with finesse and with ease, and he's well renowned for his work. He's into research, a lot of international projects in his hand, and he's world famous for his cadaveric pelviacetabular fractures, which he does the workshops every year. So over to you, my friend, Professor Vijay Sharma, for his talk on acute management of pelvic fractures.
Thank you. Respected chairpersons, dear seniors, respected seniors and dear friends. So pelvic fractures are, the most challenging injuries trauma surgeons, orthopedic surgeons, they face in trauma emergency. And it's because of the high mortality and a lot of associated injuries, we know. So many specialties are involved. Me and Vivek, we used to tell in all conferences, successful outcome of a patient with unstable pelvic fractures. It tells us how efficient trauma teamwork is in that hospital. So like this talk is for trauma surgeons, so there's nothing definitive fixation. It's all in the acute management of pelvic trauma patients. So what is the main problem here when the trauma surgeon is posted in trauma team in emergency department? Because there we work as a team, like orthopedic surgeon is there, emergency physician is there, orthopedic surgeon, trauma surgeons are there. So for orthopedic surgeon, it's a type C injury, it's a vertically unstable fracture and it will need fixation. But no, the problem is not that. Problem is very high mortality. Mortality is because of hemorrhage associated, and another thing is associated injuries, other associated injuries, which are rule rather than exception in pelvic fractures. And then don't forget the morbidity, like from skin to subcutaneous tissue to urogenital area to distal neuro, like lumbosacral trunk injuries. So there are a lot of injuries which are associated with pelvic fracture. We don't have to forget them, and we have to start working on them from the beginning. So if you look at this photograph, it's quite scary, and you can see that it's veins, and we have to understand bleeding is 85 to 90% of the cases it's the venous plexus, and 10 to 15% of the cases, around 10. And then obviously the fractures, SI joint disruption is there, fractures are there, a lot of cancellous bone, a lot of bleeding. So these are the sources of bleeding. Am I audible, Dr. Vivek? Okay.
Yeah.
So bleeding is from, and the problem is arterial, 10% arterial bleeding. If patients are not, sort of resuscitated by the maneuvers I will tell you in emergency, then you start thinking that maybe bleeding is from some arterial source, and these are the patients who cause problem. So this I have told, and the problem is associated injuries, and problem in orthopedics is orthopedic patients are associated in are so distracting injuries. They always distract the residents towards themselves. A patient with amputation, patient with compound fractures, patient with long bone fracture. Obviously, even attendants, they want you to look towards those distracting injuries, but the problem is not there. Problem is in the pelvis. And the thing is, if the same patient has a pelvic fracture with intra-abdominal injury, your mortality is more than 30%. And if patient has combination of pelvic fracture with abdominal with head injury, then the mortality rate is more than 60%. So these are quite distracting injuries sometimes, and they try to pull you towards them. Of general trauma. So old age, and if patient comes to ED with I think maybe it has been discussed in massive transfusion protocol like ABC of MTP, like if patient comes with systolic blood pressure less than cardiac, severely displaced fractures, and the requirement is much more higher. So these are the mortality. We are just looking at the mortality part first. And we have to understand that more than 50% of these fractures, they have bleeding outside pelvis. So one on the floor and 4 more. So you try to resusc the patient, you try to do the maneuvers. And at the same time, because in our emergencies, we have horizontal resuscitation, we start looking for other sources. Like in the chest, you do chest x-ray or clinical examination. Abdomen, you do fast and long bone fracture, you can do clinical examination. So when to suspect for a trauma surgery resident, deformity of pelvis, there is leg length difference, and you don't find any long bone fracture. There are abrasions or swelling around the pelvis, like moral lesions. There is scrotal or labial swelling. There and obviously blood at the meters, bleeding from rectum, and you just have to do the stability part once in emergency, because after that you have to close the pelvis. So these are a few pictures in our emergency where you can see like soft tissue defects, scrotal hematoma, vulval hematoma, and you can see swelling on the front. So these are this is the way patient presents. And this, you can see lateral compression injury. You can see the left side totally internal rotated and there's no fracture. So there's a high chance patient has got a lateral compression injury. So what to do? The most important thing is don't panic, because obviously life comes before anything else. You have to stabilize the patient. That is the most important thing. And to stabilize patient, there are 3 simple things. Close the pelvis. We'll tell you the maneuver how we can close the pelvis in the easiest way. And then fill the patient, resusc the patient. Multiple times it is discussed. And then try to find the cause so that you address the cause. So there's 3 things for the trauma resident: the close the pelvis, resusc the patient, which all of us are very well familiar with, and then try to find the cause. And then once the patient is stabilized, you will start looking to assess other injuries also. So first thing is close the pelvis. So closing the pelvis, now there are a lot of articles that binder or a sheet, simple sheet. You internally rotate both the lower limbs, and you can even tie a bandage just suprapatellar area also, just to keep it internally rotated. And then one person can try to stabilize the pelvis, and then binder can be applied, and it can be clamped at 4 points. So it provides very good circumferential initial pelvic stability. And there are articles, you apply binder and then the patient's hemodynamics, it starts improving. So most important thing is it has to be centered over greater trochanter, because earlier we used to see a lot of binders, they were quite distal or they were quite proximal, and they used to act as a abdominal binder rather than pelvic binder. So position of binder is very important. It has to be centered over the greater trochanter. So this is the first thing. So this is the X-ray before application. You can see it is totally opened pelvis. It is a APC type injury type. You can say APC3. I will just share you some classification part also. And once you apply the binder, you can see it is totally closed. Right. So binders, they reduce transfusion requirements. They reduce length of hospital stay and mortality in patients with APC injuries. Now the problem is, you apply the binder, you send the patient to orthopedic surgeon, and he will feel there is no injury. It's like APC3 is converted into a stable pelvis. And how to take care of binder? Like every 6 hours, every 5 hours, you have to loosen it. You have to look at the bony prominences, and you have to write down the note so that it is removed whenever patient is stabilized, and preferably within 24 hours of application. Otherwise, there are skin problems with the binder. And after removal of binder, obviously then we'll get scans again, because obviously it will again open up a bit, because this it looks quite stable injury. So what are other options of, now we are just looking at first thing, closing the pelvis. So what are the other options? I think in our trauma center, we had this clamp, C clamp. Now you can see that this is applied and pelvis is nicely closed. It is very good for posterior injury, like SI joint disruptions. But the problem is, you have to have X-ray beforehand, because if there is a fracture of ilium, these sharp pins, they will enter the true pelvis, and they can injure any organ. And number of surgeons look like it has to be applied by orthopedic surgeon only. Another thing is external fixators. Earlier they used to be applied in emergency, but now there are a lot of articles which say the binder, it works much better because it gives circumferential compression to the pelvis. Because fixators, anterior fixators, when you try to close the pelvis anteriorly, there's a high chance that it will open up posteriorly where the bleeding is happening. So isolated external fixators in emergency is not a good idea. So now we can see that only pelvic binder is there to close the pelvis. So this is the indication. There are indications of external fixation. You're doing a laparotomy, you're doing packing. So it should be applied, because you are packing against unstable pelvis. It will keep opening up. So in operation theater also, when you're doing any procedure, orthopedic surgeon should be with you, or you should learn the trick of external fixator so that the pelvis is closed, or it can be used as adjunct to open reduction internal fixation. So now you have closed the pelvis. Now simultaneously you are building up the patient, you are filling the patient. So crystalloid, there are changes in ATLS protocol, 1 liter crystalloid, and then obviously switching towards the blood. And Tranexia is a new addition in the last 1 gram as early as possible. Then it is the part of filling the patient. So you have closed it, you have filled it, and now you try to find out the cause, like 1 on the floor, 4 more. See, as trauma surgeon, orthopedic surgeon, you just get one image of pelvis, that is the pelvis AP view. Dr. Amit, he told me to just tell you a few points about the classification and imaging. So what are the clues on X-ray? So you have to look at iliolumbar ligament avulsion. It is just L5 transverse process avulsion, ischial spine avulsion, and unable to clearly make out sacral foramina, asymmetry of sacral foramina, significant displacement anteriorly. Obviously, it's a ring-like structure. If there is a disruption anteriorly, there is some sort of injury on the posterior part also. And then avulsion of sacrotuberous ligament. So this is a kind of X-ray, and this sacroiliac joint and posterior structures are more important than looking at anterior structures. So another thing is radiographic signs of instability. If you find SI joint disruption, there are articles of fractures, even posterior injuries you can identify on a plain X-ray. So you get CT scans, you get inlet outlet view, so many views, just to, because if you want to do a surgery, you want to have complete idea about the disruption. Otherwise, instability pattern, you can just look at AP X-ray, and if you go systematically, you can detect most of the fractures. There's posterior fracture gap rather than impaction. So it's a APC or vertical shear injury. In lateral compression injury, there is always impaction, which is a stable, stable pattern. And then I've told you about the avulsions. So why CT? Why we get CT? Now you can look AP. In AP X-ray, you can make out there is a fracture of the sacrum. There is something going on the left side of SI joint. But CT is important. Now you get look at the CT and now you plan further, because now you can see the severe disruption, type C disruption of the pelvis. So classification systems, we use two classification systems. TILE is mainly, it predicts the need for operative intervention. It looks at the stability part. But Young-Burgess classification, it tells you the mechanism of injury and it estimates mortality also. So TILE, it is a stable injury where ring is stable. Partially stable is there is incomplete injury to the posterior structure. Now you can see that on the top image, there is injury to the SI joint, but it is not completely gone. So this is TILE partially stable. And if it is totally gone, you can see on all the images, total SI joint disruption is there. So these are type C disruption according to TILE. Young-Burgess classifies according to the mechanism of injury. Lateral compression injury is the commonest injury. And then again, LC1, LC2, and LC3, depending on the severity of injury. And this is anteroposterior AP compression. These are the injuries which cause hemodynamic instability rather than LC injuries. So APC3, you can see there is disruption anteriorly, there is complete disruption posteriorly. APC2 and APC1, there is symphyseal disruption, but there is no posterior injury. But in APC2, there is posterior injury, but it's not a complete injury. So this is how the severity of injury it goes. Then you find vertical shear, and a lot of times you find combination of injury. There is combination of vertical shear with open book, or there is combination of the APC and one side APC, one side LC. So you find combinations also. So why Young classification became popular? Because it used to tell about morbidity and mortality. You can see mortality is much more higher in vertically unstable patterns and APC3 because of hemodynamic instability. And severe bleeding you can detect, and even bladder injury and urethral injury. So it gives you idea about the morbidity and mortality. So stable pelvic fracture, no one is worried. The problem is when patient is unstable. And so we just, the most important is, because if pelvic fracture looks stable and patient is unstable, then you have to look for other sources of injury. A very stable pelvic fracture will rarely do hemodynamic instability. So the problem is when the fracture is unstable and patient is unstable, then there is likely that the patient is bleeding from the pelvis. So what to do? So when to do pelvic packing, when to do embolization. So I will tell you what literature favors. But patient has to go to OT or patient has to go for embolization. Soon we are going to have hybrid theater. So both of these things, they can be done under the same roof. Because transferring the patient, then coming back, then if you plan embolization, patient again goes back. So you embolize, patient is still unstable, you can do laparotomy. So everything is going to be done under the same roof. So hybrid theater, we are going to have this. But in the meantime, what exactly we do? So this is the algorithm. So you do close, you have done resuscitation, you find the causes pelvis, and patient stabilizes. So nothing you have to do. Then it is total orthopedic patient, right? So we'll do the CT, we'll do definitive management planning. But if patient does not stabilize, that is a problem. The patient is transient responder at our place, maybe patient will go to CT angio, will embolize the patient, patient still unstable, will go to OT. But if patient is non-responder, patient is non-responding, then, and patient is fast positive, there is no ambiguity in that. Fast positive, unstable, patient goes to OT. But if patient is fast negative, unstable patient goes to OT, and we do pelvic packing and X-fix. First X-fix, close it, and then do the pelvic packing. There's no point doing a pelvic packing on a totally unstable pelvis. So now packing and angio, there are groups like North Americans and Europeans. So there is a big debate like in country like India, I think still the teaching is second line of defense is pelvic packing. X-fix, pelvic pack, and if still patient is unstable daytime, and if you have facility, then angio. Because the time of intervention packing versus angio, 45 minutes. This is article from Injury from West, and it is a recent article, 2010 or 2008 article. Blood transfusion was much less in packing group as compared to embolization group, and mortality was less in packing group. Angiography, it is less invasive, high success rate, it stops arterial bleeding, but pelvic packing, it is quick to perform, does not require any special technology, just a Phenencil incision, you can do the packing. And if still patient is unstable, patient can go for embolization. So these are the patients who benefit from embolization, persistent hypotension, continued transfusions. Like such patients in our center can go, but if you look at other parts of district hospitals and all that, and if you tell them that embolization will be done, they don't have facility of embolization. So it's a wrong teaching for them to tell them and convince them for embolization. So all these stable and unstable and transiently unstable patient would go to operation theater. So these are few slides of embolization. Now coming on to open bony pieces in the rectum, or you find bleeding coming from rectum. You find blood on the urinary meatus, or any skin disruption, you have to examine. And the thing is, now what is the role of trauma surgeon here, or GI surgeon? The colostomy, the site of colostomy. This is the big problem we face, because colostomy is done exactly where we want to give our future incisions for definitive fixation. So colostomy or diversion should be done at a higher place and with consultation with the orthopedic surgeons. So that is another point I want to make here. So these are compound injuries. Sometimes they come very early, and you can thoroughly debride them, close them, even fix them. So this was a child and came within hours. So we have done, we have managed it quickly. Urological injuries, again SPC. We do a Phenencil, we won't be able to operate upon that patient from the anterior approach. So another advice is try to tunnel the SPC to some other area so that your definitive fixation does not hinder. Nerve injury, careful examination of nerve injuries, lumbosacral plexus damages up to 45% of type C injuries. So this has to be documented when patient is going to the ward or ICU. If patient can be examined, obviously. Patient in extreme or trauma center faces a lot of time, because we have, I think, the maximum number of by any study. So I think patient dying in front of you, you have opened up, you find the retroperitoneum, there is a hematoma and patient is quite unstable. So obviously laparotomy deal with any intra-abdominal bleeding, and if you're not happy, you can do bilateral interligation and pack and send the patient to ICU. Reboa, Dr. Vivek, I cannot comment because we don't have this facility, but definitely in patients in extremes, severe lower extremity injuries where patient sometimes comes and patient is in arrest. And so there are very few articles, but there are articles where they were able to save 40 to 45% of patients with Reboa, which they claim. But since we don't have this, so I'm not the right person to comment on this. But I think trauma surgeons, they also know about the Reboa. So to summarize, if patient comes alive, so patient should remain alive. I think that is the target of all of us. So we have to quickly see whether the patient is hemodynamically stable or unstable. 3 things in emergencies: close the pelvis, fill the patient, resuscitate the patient, and then try to find out the source of bleeding, whether it is exclusively from pelvis or from some other source. Define fracture pattern, because you will just get one X-ray, and if you read it nicely, you can see it as unstable or stable, and address all potential injuries, injured areas from skin to inside. Call colleagues early. Patient goes to theater and wrongly performed SPC or it makes life difficult for orthopedics people. So don't compromise definitive reconstruction by suprapubic and stoma only after consultation. Thank you.
Thank you, Dr. Vijay. Very
important